I've had the experience myself of living with bipolar disorder. I grew up like a typical student in high school, and no real issues. I was decent grades and sports and activities. And when I went to college, like many others, I hit that period of being 18 and experienced a real tumultuous event. I had a major psychotic episode which resulted in me being in the hospital and then spending the next 7 or 8 years cycling through hospitals and psychiatric units in the Buffalo area until I finally found 12-step recovery. And when I got into Narcotics Anonymous, that really did change the course of my life. It changed, who I was as a person, and it really was, I guess, the catalyst for my recovery from mental illness and bipolar. I still consider myself to be in recovery. It's my own personal opinion that recovery is an ongoing process, and that even though I've been stable for many years, I consider to be more like being in remission. So we hear about cancer survivors being in remission and in recovery. I consider myself being in remission because I know from what I experienced as a professional, because I've worked as a counselor in mental health clinics and other places, that it is possible to have a relapse if one doesn't do what they need to do to maintain their mental health. So I've been actively involved with that. I've most recently worked also before the current job I have at the Mental Health Association of Erie County and Concord Buffalo. I was a director of community advocacy where I did a lot of training in the community around mental health. I'm a mental health first aid instructor. So I've done a lot of things around education that has really been something that I've really kind of devoted my life to over the last, say, 10 years or so. But this piece here around spirituality and mental health has been a real thing that I've really been interested in, very much because of my own journey. When I was going through my struggles in my late teens and mid-20s, I did find a source of comfort in my beliefs. And even though I struggled, I had the sense that there was something. I didn't exactly know what it was, but I knew there was something called God that could help me. And so I consistently prayed. I would, in fact, I remember one instance that is quite remarkable. I was a patient at the Buffalo Psychiatric Center. In Buffalo, that's one of the major institutions, and this is a place where oftentimes, we hear about people being institutionalized for long periods of time. That's where I was, and I'll never forget. I was in this unit with men. And I had taken my Bible with me. It was a Bible I'd gotten for confirmation, had my name on it and everything. And so I couldn't find it. I was looking all over for it. And I went and I found it in one of the shower stalls, destroyed. And I mean, I was crushed. I immediately said to myself, I've got to get out of this place. This is not, this is not where I want to be. So for me, along with other examples of just having support, you heard about Sarah earlier talking today about the support she received and how we receive, and Amy references as well about support we receive from other people, and is what carries us through. And for me, that's how I see God at work, is through the people. And to have a supportive community, like we're going to talk about a little bit later in this program, is really, for me, what it's all about when it comes to the church's role in helping with mental illness and helping those who might be struggling. So I think what I'd like to say, if anything, to start off, have been involved, for better or for worse, with the lives of those living with mental illness. But I think now is certainly the time that we can certainly take advantage of, and that's, for lack of a better term, but take advantage of where we're at right now as a society, as how we look at mental health, and what we can do to help others. And I think we have, if anything, an obligation to do that. You talk about the work of Jesus, and you talk about the work that was done in the early church to help other people. That's really what we're taught to do, is to serve others. So I know in the work that I do and the work that many other people do, whether they be in a faith-based setting or not, it's about service. In the end, it's about service. So, like I said, today we're going to cover a number of topics. So, First of all, these are some of the terms that we're going to be looking at as we go through today. So, as you'll see, they're all pretty self-explanatory. The first one, behavioral health, is something that, it's basically a state of mind and well-being, and emotional being. And we talk about, behavioral health. It's a broad term. It's used a lot these days. So behavioral health is often applies to mental illness, substance use disorders, things of that sort. And so behavioral health is a commonly used phrase that kind of covers, in a general sense, what people think of as, say, mental health and substance use disorders. Now, care and community, that's really where essentially we come in as the church. When you think about it, we have the ability to show compassion and show a sense of caring for those who may be vulnerable, for those who may need help. So here we want to be able to help those by being accepting, sympathetic, well-informed. And that's why we're here today at this W.I.S.E conference. Because I think it goes without saying, for those of you who have come today, you are to some degree accepting, I would imagine, if not very accepting, but also want to be welcoming. And you also want to know what to do and how to help, and certainly where to take those steps to be more proactive in your congregations. Now, mental health itself is another term that's often used, and really, mental health essentially is like we know, is basically a state of well-being, like it says there, in which an individual recognizes his or her own abilities, coping with the normal stressors of life. And, everybody deals with mental health. Mental health, as I consider to be, and many others consider to be, on a spectrum. So I teach a program called Mental Health First Aid. And Mental Health First Aid is a 8-hour certification program for those who might want to learn about signs and symptoms of mental illness, how to intervene in a crisis, to know what to do to help someone that might be even in need of additional services. So within the Mental Health First Aid program, we talk about mental health being on a spectrum from being well to unwell or recovering. So everybody falls somewhere on that spectrum, being unwell to well or recovering. And as I like to say, on any given day, we can be on anywhere on that spectrum. I might be having a great day, things are clicking, I'm having a great day, I'm well. On the other hand, I might be having a day, I'm all stressed out, I'm at work, the guy cut me off on the road, my appointment didn't show up on time, my flight yesterday was super late, which it was. I ended up leaving the airport probably an hour and a half later than intended. So we just, life happens. It affects our mental health. So, but with that, most people are able to roll with these things, and I think as human beings we're resilient, to some degree. But some people do struggle, and so we know that when people do have these struggles, their mental health is compromised. So with that, we know that the idea is to be able to maintain relationships, also to feel productive, by going to school or going to work, by being able to carry out one's daily activities. So those are the three major criteria we look at when we talk about recovery and mental health. So the idea here is that what we want to do is to promote these things within our settings and with our churches, to be able to encourage people to seek help if they need it. So, and also the idea of, once again, destigmatizing and letting people know that within the confines of the church that they can talk about these things to get the help that they need. Another tool, and we're going to learn about this also a little bit later, but a model of friendship. Basically, we all want to be accepted, I think. I think that's just a common core belief and a core value, that as human beings we want to be accepted by others. And when you think about it, this idea of being connected to a community is so important for all of us. When you consider a person living with a mental illness, they might be detached or disconnected from a support system, or they might feel like they're not welcome, or they might just essentially not have family to rely on. So by providing this place, this space where they can feel accepted and welcomed is so very important. So very important. Because in the end, if you feel like you have a place where you belong, then hopefully you're more likely to feel like you can do other things, like you can work, you can integrate into the broader community. But the church is in a prime place to do that, because like I said before, this is what I believe that we're asked to do. So, when you think about it, there's a lot of things here. Now, certainly, it is a powerful deterrent to the stigmatization that exists. And there is so much stigma around mental illness. If we are able to come together and help others, we know that we can address that as it is. So, what is the faith community's role? Okay, compassion. I think I mentioned that before. Empathy is a big one. I went to an interesting talk the other night with Alan Alda. Of course, we probably all know Alan Alda from the show MASH, but he also has been involved for the last 20-some-odd years or so with a communication science program through Stony Brook University in New York State. And one of the things he talked about was the importance of empathy and listening. And those are the two key ingredients when we are with someone who might be in the midst of a struggle. I'll just call it that. We heard the word present, right? Alan mentioned that right as we concluded our lunch. Being present is invaluable. When you are with someone and you are engaged and they know you're listening, that can be such a powerful tool to help them, so that they know that you're not just being there because it's convenient or because you think it's a good thing to do. You're really being there with them. So by being present and showing empathy, listening, that is essential. And I think in the end, so I took counseling classes. I became an addictions counselor. But that's one of the first things we learned in our counseling classes, was how to be present, how to be mindful, how to, even when we sit with someone, how to position ourselves, having an open stance. All that is so important to letting that person know, even through our nonverbals, that we're present with them. So, serious mental illness. This is a term that has been around for a while. Before, they used to call it severe persistent mental illness. It seems like every 15, 20 years, the definitions change. What it comes down to, though, is with severe mental illness, it impacts a person's life to the degree that oftentimes they can't function as they typically would or would want to, or that mainstream society would. To the degree that they may not be able to hold a job consistently, or they may struggle with those relationships or those daily activities like I talked about before. So when you think about it, there is, we call it the DSM, Diagnostic Statistical Manual. It is, as they say, the Bible of psychiatry. And in the DSM, there are all of the mental health disorders with all, we call it the diagnostic criteria for these conditions that basically are used to diagnose people. So, like myself, I have bipolar disorder. So if I were to go in and see my psychiatrist or my therapist, especially when I was first having my issues, they would ask a series of questions. They would go through like an assessment. And through that assessment, they would determine if I meet, as we say, the criteria for that condition. Now, what we know also is that basically, serious mental illness, we're talking about typically currently or within the last year for someone, because we do know that people, sometimes it's episodic, right? For some people, they might experience a major episode, but then they go into a period of remission for a while. But then that episode, or that they may have another episode. So what we looked at, is in terms of a lifetime. Right now, they've actually changed some of the criteria where they now call these conditions mild, moderate, and severe in terms of the degree, I guess you could say, of what the way that illness is. So we know that if you meet X number of the criteria, it would be mild. So a person can have a mild anxiety disorder, a person can have moderate or even severe anxiety disorder. So that's one way to look at it. Now, as you see, that excludes developmental or substance disorders. Oftentimes people think that developmental delays or developmental challenges are also mental health challenges, but they are different, in terms of what they are described as. We do know that people with developmental challenges can also have co-occurring mental health disorders, but they are not always the same thing. This is the one right here, though. This is the one that has really been something that I think has happened, and we need to address it, because oftentimes this is where sometimes the damage is done, and even if it's not intended. But we know that when we're silent in the congregation, when we're not speaking about these issues in our churches, that's when problems can continue. And so we know that this is the way that many families and many churches deal with these issues. We were in our core group just before, and we talked about the idea of shame. And so shame is something that really affects a lot of people, because they really don't want to talk about it because they feel like there's something wrong with that person, or it's seen as being immoral. One thing we know is that when it comes to mental illness, it's not a moral issue. The person has a brain disorder. There's something physiologically wrong with their brain. So how does that impact a person? Well, it can impact their behavior, which is why people often look at it as being moral in nature, but the reality is it's not. And I'll just say real quickly, because I always forget to do this, if you have any questions during this talk, feel free to let me know.
I have a question.
Yes, please.
If you don't mind.
Sure.
I know there are different ways to present.
Sure. So just so those who might be viewing this online, the question is, how do clergy know when it's appropriate to refer someone for treatment, say with bipolar disorder, versus when they know they might be able to handle that situation on themselves or on their own? So, well, first of all, I think this is really what it comes down to, knowing your own limitations. And I think what it comes down to is so in my congregation, our pastor, who actually just left us last year, was a clinical social worker. So obviously he has training, professional training around understanding mental health and mental illness and knowing what to look for. So he's equipped to know when to address this issue and how to respond. Many, if not most, clergy, however, don't have that kind of experience. Now, mind you, there is, I guess in seminary there might be pastoral care or some brief, education around mental health, but that really obviously isn't the focus. It's my personal belief that in most cases you probably do want to refer that person to a professional if you really believe it is a disorder like you're describing. Because we know that the earlier the intervention, the better. In other words, time is of the essence. So when you think about it, there is a program called Mental Health First Aid, and I think I mentioned that. So Mental Health First Aid is this program where it teaches about signs and symptoms. It's offered throughout the country. So one thing I do encourage anybody to do, and we've actually done these in my area. I trained a number of church leaders and clergy on this about a year ago. But so Mental Health First Aid is the kind of program that does just that. It teaches you when to intervene, how to intervene, where to refer people to. And if you have a better understanding of what these conditions are, and you're educated, then you're better able to know, I should say, when to make that referral, when to step in, and when to know, okay, I can't handle this, maybe it's time to have them see someone on a professional basis. So I don't know if that answers your question, but I think a lot of it comes down to, like I said, understanding your own limitations and understanding really that your role is not to treat the person. I mean, your role may be there to support them in a spiritual sense, to help them to understand that, that God is with them and is present, but also that God is also with the professionals, hopefully, that are helping, and the others that are in their treatment team.
But if someone thinks they're bipolar, they don't know.
Right.
And thinks he is.
Yeah. Yeah. So the question is, what if the person isn't really sure if they have bipolar disorder?
Yeah.
What does the clergy do then? Well, I would say if you don't know, then refer to those who do. I mean, that would be really my initial response, because we don't want to pretend that we know or advise a person in an incorrect way. I think really what we're trying to do is if a person comes to you and says, I think I have bipolar disorder, you might ask them, so what are you experiencing? And they tell you, well, I can't sleep, or I can't stop thinking about this, or just all this energy, or they might be depressed. That's another part of bipolar disorder. I can't get out of bed, I'm not eating, so they're describing things that just don't seem right. I think you'll get a pretty clear sense that, okay, I think it's time for you maybe to see someone and to encourage them. Because you have to remember, you might encourage them to seek help, but they came to you because they trust you. And they may not trust the medical professionals. And that happens a lot. Yeah. So I think when you talk about, so in terms of the person's best interest, I think it comes down to your own judgment, really, in the end. And knowing that, well, first of all, there are resources in many communities. Now, I think it depends on where you live. Some areas are better resourced than others. But when you think about it, hopefully there might be places that they can go to that they can get professional help. If not, there are other ways to seek help as well. But whether it be support groups or online, work. But I think your role as a pastor, as a clergy person, is to really be that intervention and to be that one to get them to that proper level of care. Now, stigma, I think we all know what stigma is, so I don't even need to describe it for you. Stigma has existed since the dawn of time, I guess you could say. So we know that with stigma comes shame. Also, we know that stigma keeps people from getting help. I think Sarah mentioned the idea of the broken leg in her talk earlier. It takes a person an average of 10 years to seek help when they have a mental health condition. So imagine having a broken leg for 10 years and not getting help for that. That's devastating. But a lot of that has to do with stigma. Yes?
That's a stat that you do on the internet or something, or where's that stat come from? Doesn't matter. Is it a definite recent stat?
It's what's commonly used. I can't remember where it's referenced, but I've seen it in many places.
Okay.
Yeah. So, but we know that, I mean, the bottom line is, and actually I did get that in my mental health first aid training, but the idea is that it could be 2 years, 5 years, 10 years. The bottom line is the person is getting help when they need it because of stigma. And the longer it takes for that person to get help, typically the worse their condition gets. That's why we want to provide that intervention early. So that might be even a better response to your question about, where does that come from? So a lot of it has to do to lack of knowledge, lack of education. We know that people in general aren't well informed. That happens a lot too. So what I'm going to do now is cover briefly disorders and kind of just talk about a couple examples of what they're like, and like I talked about before, the criteria. So depression, major depressive disorder, typically lasts for at least 2 weeks. It's not just sadness. We've all experienced sadness, but when that sadness doesn't go away, or we're experiencing other problems, we know then that that person might be experiencing depressive disorder. So as you see there, it affects those things like emotions, thinking, behavior, physical well-being, work, satisfying relationships. When those things are affected by, in that way, and there's other things like here, you'll see the symptoms, we know then that's time for that person to seek some help. So, as I said, if you have this information available, and this information, you were asking like how to know when to help someone, this information actually is readily available online. There's some very reputable websites, like NAMI, National Alliance on Mental Illness, has good information online about what to look for and how to help someone. So if you know what the symptoms are, then you have a better idea of if that person that's coming to you is dealing with this. So that empty mood, hopelessness is a big one. Feeling hopeless, and then certainly as it goes down, one of the ones there that isn't listed, like the talking about death or those thoughts of suicide. That's certainly one of the end results of depression for many people. But loss of interest or pleasure in hobbies and activities. That's one that also comes up for people. For myself, I love music. Music is like one of my favorite things in the world. When I was depressed in my bipolar disorder episode, I lost all interest in music. I couldn't listen to a song and get anything out of it, which is really unlike me. So I knew then that something was going on. I didn't know exactly what it was, but I knew something was happening. So you see there, those are the symptoms of depression. You see that there's also things like the sleep disturbances, early awakening, as I said, thoughts of death or suicide attempts. All these could point to depression. As I said before, these are the things that when a person goes into a trained professional, that's what they ask about. Have you ever than thinking about death or suicide. How is your appetite? How are you sleeping? Those are the kind of questions that they routinely go through when assessing someone for this disorder. There can also be physical pain, believe it or not, from depression. People actually have physical complaints. They go to their doctor not knowing why they're feeling that way. Now, I don't know about you, but last time I went to my doctor for a physical, they asked me, how's your mood? That's becoming more common these days, that doctors will actually ask these questions. And if you indicate that your mood is low or that you're not doing well, they might give you a questionnaire. And that questionnaire might be a depression screening. So we know that this information is getting out there. Anxiety is you can almost say on the flip side of depression. However, they go hand in hand. Many people who live with depression also deal with anxiety and vice versa. You could have a person who's experiencing depression, but they're not able to get to work. So since they can't get to work, they get anxious. They experience anxiety. Or you have someone who's experiencing anxiety. They might have an anxiety disorder. Say they might have obsessive compulsive disorder. And they're going through all those behaviors and so forth. And they don't know why, and then they're really stuck. So they might become depressed as a result of that. So, it's basically the body's natural response. We talk about the fight or flight or freeze. That's really when we think about anxiety. It comes from that as they say, that reptilian brain of ours, that goes way back, once again, to the dawn of mankind. That's what happens. So we experience anxiety. Now, everybody experiences anxiety at one time or another. Flying here, hit a little bit of turbulence, okay? Anxiety kind of goes up a little bit. I also talk about my first date. Oftentimes, think about your first date. Like I remember, blind date, roller skating with sweaty palms, all that, anxiety. But it wasn't a disorder. It was just typical anxiety. Now, the difference is that, like with depression, if it goes on for 2 weeks, 3 weeks, and it just isn't going away, and it's just persisting, that's maybe when it's time to get some help. So basically, you're feeling threatened or under pressure or facing a stressful situation. These are the disorders that we know of with anxiety. There's generalized anxiety disorder, panic disorder, social phobia, specific phobia, obsessive compulsive disorder, and PTSD. So all of these are different disorders that basically fall under the category of anxiety. Now, the thing to recognize is that some are more impactful than others. Specific phobias are things like being afraid of insects or cats or dogs or heights, whatever. That one may not impact a person as much as, say, OCD, where that person really just can't get out of the house because they are continually going through those ritualistic behaviors, whatever they might be. So we know that some can be more impactful. Social phobia can be crushing for some people. They just can't handle social situations. So the anxiety increases when they go through that. PTSD is one that, of course, is getting a lot of talk these days. We learn, in fact, the other workshop here, trauma-informed churches. Trauma is becoming one of the, dare I say, hottest topics of mental health these days. We know that trauma affects people. 90% of people living with mental illness or addiction have experienced trauma at some time in their life, oftentimes as a child. So trauma is a major contributor to these conditions. So it might be PTSD, which isn't just for veterans, isn't just for those who have served in the war. It could be someone who's experienced abuse, physical abuse, verbal abuse, neglect. It could be part of a natural weather event. It could be witnessing a crime, being in a car accident. Anything that really affects a person in a very heightened kind of way, a very almost tragic way, can be considered to be traumatic. Now, we know also that what affects one person might not affect another as far as being trauma. So I might be in a car accident with Amy. It's Amy, right? And Amy might be fine, walking away, oh, no problem. I might be very anxious as a result and experience that trauma because of how we experience trauma differently. Basil Vanderkolk, I think that's the name correctly, wrote this book called The Body Keeps a Score. Excellent book on trauma. It is he's a groundbreaking pioneer in the world of trauma, and he talks about a couple that were in a car crash and how one is able to bounce back from this trauma and the other, is not so much. So We know that trauma exists, and frankly, we've all experienced trauma of one kind or another in our lifetimes. Losing a loved one can be traumatic. It just depends on the degree and the severity. Now here's some of the symptoms. That surge of overwhelming panic, heart palpitations, hyperventilation. If anybody here has experienced a panic attack or an anxiety attack, that's that really quick onset of anxiety. So when these things happen, obviously it's a physical reaction oftentimes, but it also can be mental too, where the person's thinking just continues to keep going. But often, more than not, it is physical in nature when a person experiences anxiety. So what we know is that when a person experiences anxiety, it can be incapacitating. They might have trouble with working. They might have trouble with other functions they normally would. Schizophrenia is, as I mentioned, a very severe mental illness. And with this, we know that that person often might have this detachment from reality where they essentially lose touch. And it could be distorted thoughts. It could be having what we call delusions. Delusions are false beliefs grounded in reality. We know that when a person experiences delusions, they might have a thought that they are something or someone, or that they're not, but you can't get them to change their mind. Of course, we always hear the idea of the person thinks that they're Christ or that they're the Mother Mary. That's oftentimes the one they reference. But that person, you can't get them to change their mind no matter what. They are fixed. You can't get that away from them. Hallucinations is another one, where a person might have a sensory reaction. They either see things, hear things, touch, taste, feel, smell, things that aren't there. I was working a program several years ago, and one of the clients had what we call olfactory hallucinations, where you smell something that isn't there. And whenever he would have the experience of smelling burning, we knew that that was an early warning sign that he could be headed for a relapse. Because he'd come in and he'd say, what's burning? We would know that that's a red flag. So we know that happens. Loss of motivation involving self-care, that was mentioned too earlier in our program. Social withdrawal is a big one. We know that when people pull away and begin to isolate, that is definitely a red flag and something to look for. So all these things, and also not to mention, a person doesn't have to be experiencing all these symptoms that I've been showing for these different disorders, but usually it's several of them, if not more or less. So we know that to meet the criteria, like we call it, you have to be having some of these. Bipolar disorder, like the one that you referenced before, is one where a person experiences highs and lows. There's different types of bipolar disorder. There's bipolar 1, bipolar 2. Bipolar 1 tends to be more associated with that mania. Oftentimes it can have psychosis associated with it. So that's what I dealt with. In my illness, I dealt with the mania, but I also had psychotic features. Bipolar 2 tends to be more based with a person who has depression, but they might have briefer periods of what we call hypomania. And hypomania essentially is when a person might be exhibiting some type of manic symptoms, but not at that high level or high intensity. But you see there's the other types of symptoms as well. Oftentimes, like I said, that long periods of no sleep, rapid thinking and speech, lack of inhibitions. If anybody has seen the television show Homeland, have you seen it? Oh yeah. Oh yeah. So my wife has been watching Homeland, which is on Showtime. We have Hulu, so we're going to kind of catch it up. But Homeland is a show, TV show about a CIA agent who lives with bipolar disorder. And I must say, it's pretty riveting. And for me myself, living with this condition, to watch this character, Carrie Madison, go through this, it's kind of hard sometimes because I can really relate to the depiction of what she does in this show. Now, to kind of go off on a little tangent, some people look at mental illness in the media, and oftentimes it's distorted and oftentimes sensationalized and not represented well. We know that, of course. Think about the movie Psycho, right? That was, of course, one of the first movies that came out that really talked about mental illness in a very negative way. All About Eve, I think, was another one. But with Homeland, this character really does struggle, but it's done in I'd say, in my estimation, a pretty realistic way. And it handles it in a very realistic way as well. I mean, it doesn't sugarcoat it, but it does, I think, the characters that revolve around her are trying to help it. It's just an interesting example of what a person goes through. So if you watch that show, you'll see many of these types of symptoms exhibited. Then we have substance use disorders. Substance use disorders are included because, frankly, they're most common of the behavioral health disorders. So when you think about it, there's obviously all these things here: alcohol, cannabis, marijuana, as is known as, hallucinogens. Opioids, as we know, is certainly taking a lot of the focus these days with what people are dealing with when it comes to substance use disorders. Unfortunately, the opioid epidemic is impacting people in ways like it never has before. And I think it's reaching these epidemic proportions that people are waking up and realizing that we need to do something about this. And there's all kinds of beliefs on how to approach this, but the bottom line is I don't think anybody has the real answer yet. I think we're still trying to find a way to address this problem. So with more awareness, more education, hopefully we'll be able to kind of resolve some of these issues and maybe save some lives. There's other drugs there, sedatives, Xanax, Klonopin, anxiolytics. Those are for anxiety. Stimulants, cocaine, methamphetamine. So these drugs, including alcohol, can all be something that can also trigger or be co-occurring with a mental health disorder. So a person might have alcohol dependence or alcohol dependence severe. And they might also have a co-occurring anxiety disorder, a co-occurring depressive disorder. So they do go hand in hand. And oftentimes people too will have a mental health disorder, but they'll use the substance to manage it. We know that many people will use marijuana if they have anxiety. That's not uncommon whatsoever. Or alcohol, because it helps them to kind of lower their anxiety. And they feel that it works better than prescribed medications. And I have no comment on that. But the reality is why would you have a comment? I know that with drugs that you get off the street, you don't know where they're coming from, you don't know what's in it. So it's almost like playing Russian roulette, in a sense. You may not die, but you never know what's going to happen. Our next door neighbor, 2 years ago, her son went to a music festival in Delaware, big music festival. He took something, doesn't know what it was, went into a major psychotic episode to the point where he was hospitalized. He was over the age of 18. His parents couldn't even talk to the medical professionals because of HIPAA laws. HIPAA is the federal protection for those who are medical patients. It was a nightmare. Now, fortunately, he's made a full recovery. But for about 3 months, it was really touch or go. I mean, like whatever he took, really, and he doesn't know what it is. Nobody knows what he took. But it was that severe that his life was affected. They had to mercy flight him. We have a program where they fly people, who have medical emergencies from Delaware back to Buffalo to get him medical treatment. Yes.
Question.
Yes.
Illinois seems to be...
That's a hard question in many ways. I have my own personal beliefs, so I'm going to take off my professional hat and step over here with my personal beliefs. I believe that things like marijuana can oftentimes exacerbate symptoms and exacerbate conditions, no matter what they are. And like I just mentioned, oftentimes you don't know what you're getting. Now, if it's legalized, of course, it's going to be, I guess you could say, somewhat regulated. So people will probably have a better idea of what they are getting. But if you have, now, there's also the consideration, too, for our youth. We know that many addiction disorders begin between the ages of, say, 14 and 24. We also know that the human brain is still developing till about the age of 24, 25. So if a person uses a substance, alcohol, marijuana, you name it, at an early age, they're more likely to develop a disorder, a dependence disorder. The problem I have with legalization is that it's almost like saying it's okay, it's sanctioning it. And mind, we have the same problem with alcohol too. I have my thoughts about alcohol as well. But there are also people who do use it responsibly. So I don't know, it's hard to kind of give a blanket answer to that. However, I do believe, we need education. We need to make sure that, people are given the opportunity to have alternatives. I think a lot of people use substances because of a lot of reasons. Environment, peers, just pressure, stress. So if we're able to teach people tools and give them opportunities to do things besides using substances, maybe we wouldn't have some of the problems we already have today. But as far as the legalization piece goes, like I said, personally speaking, I'm not the hugest fan. There are medical reasons, which I understand people use it for, which I get that. But that isn't the same kind of thing as recreational marijuana. Now, as I said, the criteria we have here, one of the big ones we have here is taking larger amounts than intended. There's this idea of tolerance. So you might have an individual who at one time might have needed 2 beers to get a certain sensation. Then after 6 months, it might be 4 beers. After a year, it might be 6 beers. When I say beers, I mean like 12-ounce cans or bottles. So the more that they need to get that same effect is what we call tolerance. And when a person develops tolerance, then they're more at risk for withdrawal. Because if you take it away, then it's going to cause that person to have a physical reaction. Just today on Facebook, one of my very good friends, who I've known for a long time, posted that he's going through caffeine withdrawal. He was just in the hospital for some issues and came out. And he said, caffeine withdrawal, it really sucks. Now, I don't drink coffee, right? Never really drank coffee, but my wife drinks coffee. If she didn't have her coffee, that would not be a pretty thing. So, but caffeine is a substance. Am I right? It's a substance, and it affects the way we think. It affects the way we feel. People don't often think of it that way, but it is. But that's a prime example of teaching people about withdrawal, and as well as tolerance. I mean, I have friends who could drink a pot of coffee at 10 o'clock at night and have no trouble getting to sleep. That's tolerance, right? Right. On the other hand, someone like me, if I drink a cup of coffee at 5 o'clock, I can't get to sleep. So we're all different. But there you have, also you see there's social, occupational, recreational activities given up. One thing we know that people that deal with substance disorders, oftentimes it bleeds into their family life, their social life, their work life, where they're basically have issues and problems, with these areas, to the point where jobs may be lost, relationships may be severed, their social connections are disrupted. When these things happen, they can be basically just horrific when you think what it does to people's lives. So let's kind of transition here and talking about, it says here, the implication of mental illness on spirituality. The first one we talk about is isolation from family and the faith community. So really, when you think about it, for those dealing with mental illness, that idea of being alone and abandoned is really, really impactful. I even know from my own experience, when I was young and going through whatever it was I was going through, there were certainly times I felt disconnected from my peers. I stopped going to church. In fact, I didn't attend church. I attended church until I was 18, and then I stopped, and I came back when I was 25. But for that 7-year period or so, I was out there. I didn't feel like I was welcomed. I didn't feel like I could go. I didn't feel like I belonged. Even though I had belief in God, I didn't think that was a place where I could feel comfortable going. For some people, now this wasn't me, but some people in the context of their mental illness, they may be angry at God. Or they might say, why me, God? What have I done to deserve this, God? Right? And in that respect, we know that for those folks, it's going to be very hard to get them into a spiritual setting or a faith-based setting if they do have that anger, that emotion around that. And then sometimes when people pray, God, please help me, mercy, God, and they don't get a response. God, where are you? They say that, and God doesn't show up for them, or things don't turn out the way that they intend. That's another thing that can create that disconnect, or even that anger. So we know that as well. And then of course the idea of stigma, and then also that last one, hallucinations and delusions. Think about this. Did Moses have a hallucination when he saw the burning bush, or was it a delusion? When Paul, heard the heard God speaking to him, telling him, or Jesus rather, saying, why are you persecuting me? Were these mystical experiences, or were they mental health disorders? Now, I tend to think that the lines may be blurred. That's my personal belief. When you talk about true spiritual experiences which can't be explained, which might seem to be mental health in nature. Now, this is once again my personal belief. I don't know if this is, there may be some clinical work behind this, but I tend to think that we can hear messages from God. Maybe not God directly speaking to us, but we can get these feelings that God might be directing us in our lives, and I believe that God has spoken to some people. I really do believe that, and I believe that in the context of that, it's changed lives. It really has. We have, of course, our great prophets, Saint Teresa of Avila, Thomas Merton, all these icons, Mother Teresa, Mahatma Gandhi, all these spiritual gurus and leaders, oftentimes describe this experience where they felt this communion with God. So that's something that I think is really important to think about, because we can't discount a person's experience, right? We can't just say, just ignore them. They're sick. There may be something more than what we'd see. I know that the Eastern world looks at it a lot differently than the Western world when you talk about mental health. In many Eastern cultures, mental health and mental illness is actually, it isn't an illness. It's considered to be a gift. And so I know there's that belief system too, and they're treated differently, people are looked at differently, and oftentimes accepted differently. So we know that there's a history. We know that the relationships haven't always been positive. We know that, for instance, however, some of the major religious traditions have been at the forefront of care in terms of helping others. That there have been communities that have been welcoming of others. But from the data, faith community overlooks the needs of the mentally ill. It's prevalent but nearly invisible. So we know that through our clinical research that's been done, that oftentimes churches still aren't addressing these needs as best as they can. So here's some barriers. You heard this already, the idea of casserole disease. That certainly is a barrier, because often, as we heard, Amy or Sarah describe, or Amy, I can't remember who, said that who brings the casserole when a person's experiencing a mental health disorder, right? Silence, we talked about that. Lack of knowledge, media, all these things I discussed already. These are the barriers. Now, one of the things we can do is learn how to partner with our community partners. NAMI, as was mentioned today, is a wonderful partner, and there's other organizations in our communities that we can link with. I think we should be working together. We should be building bridges, not walls. Now, there's cultural considerations. Certainly, depending on the culture that you're from, mental health is looked at differently. In the African American culture, there's a lot of stigma still around mental illness. The way it's looked at, the way it's approached, the way it's treated. We know that. So we have to understand for the person, we have to ask them, to the people that are working with them, what's it like for you? What are you experiencing? Ask the person, what do they need? If they do have a spiritual leader, who would they go to? So this is the kind of thing that, as I said, when we're working with our providers, they need to be asking these questions as well, to integrate a person's spiritual life into that treatment that they're receiving. I think that's really crucial, because a lot of people still do rely very much on their spiritual lives and their mental health. But if we bring the two together, I think we can get a much better result. So the cultural questions are things like, what do you call this, right? That's one simple one right there. What do you think caused it? Why? Some people say, someone told me I have a demon. That's how it's often, sometimes looked at for some people. What do you think is going to happen, if this persists? And how's it going to affect your life? So basically, families need an accepting, sympathetic, well-informed community. And the role of the faith community is twofold, as you see that, being involved in the care of those who are mentally challenged, and advocacy to change the stigma. So really, like I said, this is where the faith communities can come in, to be that integral part of changing the culture within the congregation, but also the broader community. And then, of course, being able to express their feelings without fear of condemnation. once again, being able to be open is so important. I'm going to just talk briefly about some of the successful models before we wrap up. As you see here, you've heard all today about what we have here with the Mental Health Network. We're really proud of the work that we've been doing. And essentially, if you go to our website, you can just Google Mental Health Network, UCC Mental Health Network. You'll see a lot of our tools. We're developing our W.I.S.E resource booklet, like I mentioned. So that's really exciting. But a lot of information is very valuable that you can get right there. John Swinton, some of you may have heard of John Swinton. He developed the model of friendship, which I talked about earlier. But it's the whole idea behind acceptance and friendship, and creating a welcoming, empathetic kind of experience. Education. Remember WWJD? What would Jesus do? Right? That's kind of what it's all about. How would Jesus treat one of our folks? Or me, for that matter, too. I live with it. How would he treat me? We should be treating others like we'd want to be treated. And then, of course, a plan. We talk about the W.I.S.E plan. And that could be part of this, but having a plan. And then relationships with other agencies in the community. Once again, that partnership is really important. That's one thing that I'm really excited to be doing in my areas. We're starting to work with local congregations and faith communities to get that conversation going on a broader level. And then through Mental Health Ministries, there's a Creating Caring Faith Communities. There's a 5-step program, as you see there, based on education, commitment to intentional care, welcoming into the faith community, support, and advocacy. So, of course, once again, like I said, through our website and other resources, you can educate members. You can have NAMI come in. There's ways to do that. But it's intentional. So, like even with our W.I.S.E covenant that we are encouraging churches to adopt, some people say, well, we do this already. We have mental health, this and mental health. No, it needs to be intentional. It needs to be declared that this is who we are as a church. And then support, advocacy, those things are very important as well, being able to be those kind of voices. And then finally, communities of compassion and justice. Once again, education, identification of justice issues, because this actually is a justice issue as well. When you think about mental health and mental illness and how people are treated, because it does go into the mental health system within their jails and prisons. So it is a wider issue as well. And then once again, you see they're having a specific plan. And then finally, Pathways to Promise. That's the one that has been around for a while. That's the one that actually was the precursor to the Mental Health Network that Alan referenced. So there's a toolkit, there's national resources, monthly activities, and also information on starting and maintaining a mental health ministry. So Pathways to Promise is a really good resource. It's ecumenical, so it goes across different faith communities and faith traditions. So I highly encourage you to check that one out as well. And with that concludes my talk, my presentation. My contact information is there if you have any further questions. But it's now 2 o'clock, so I want to thank you. And I'll be around today as well, so if you have any questions, you can just kind of follow up and check in, and be happy to try to answer. So thank you.